Brilliant. Yeah, so as Laura said, I'm going to present today some of the findings from a rapid evidence synthesis we did. I'm going to speak for roughly 30 minutes, I think. I haven't actually timed myself, might be a little bit longer, but there will definitely be some time for questions at the end if anybody has any. So welcome, nice to see so many of you here, including a few familiar faces. I'm Hannah Long, a postdoctoral research associate for the Healthier Futures Research Platform. And yeah, today I'm going to present the findings of a rapid evidence synthesis, which investigated the health impact of poor housing. This piece of research was requested by the Greater Manchester Combined Authorities, who are made up of the 10 local councils in Greater Manchester. It was requested by their housing team, but their population health team are now also quite closely involved. So I'm going to begin by explaining sort of the backstory to this piece of research. I'm sure many of you know that housing is widely acknowledged to be a key determinant of health, and there's been a growing policy focus on housing standards in Greater Manchester. And this is in the context or against the backdrop of the Greater Manchester's 2023 devolution deal, the death of Awab Ishaq due to mould exposure in Rochdale, and various opportunities that are now presented through the launch of the Integrated Care Partnership Strategy and its accompanying ICP Joint Forward Plan. And then last year, in 2023, GMCA's research teams were asked by Reform Delivery Executive to produce an estimate for the cost of poor quality housing to health in Greater Manchester. Now, much of this sort of data or evidence, I believe, is projected at a national level, but the data is or has been sort of extrapolatable, if that's a word, to a regional level. And the GMCA have estimated the cost of housing hazards, category 1 housing hazards, to be £62 million annually, with a wider societal cost of £943 million. Quite a lot of money. Category 1 hazards include things like damp and mould, excess cold, excess heat, asbestos, crowding, lighting, noise, falling, structural integrity of housing. You get the idea. After these costs were produced, these cost estimates were produced, it was then agreed that further work was needed by GMCA to improve the information that they have about the condition of our housing stock in Greater Manchester. So that's what's happening. This is a diagram of the plan and the phases of work to be carried out by GMCA and their partners, which include the University of Manchester, but also NHS Strategic Intelligence, and I'm sure there are others too. And to summarise this, essentially GMCA are going to assess the housing stock condition in Greater Manchester. The level or the granularity of these housing condition data is not yet decided for certain. Ideally, GMCA want to be able to look down to the address level, so know the sort of physical condition and state of repair of individual houses. But in conversations so far, it seems that availability to the right data sets and access to these data sets, it's beginning to look more likely that the data might be down to the LSOA level, also known as lower layer super output areas. And for context, LSOAs typically comprise about 400 to 1,200 households and usually have a population of between 1 and 3,000 people. But in parallel with this housing stock assessment, some of the health data of residents in Greater Manchester will be accessed, and this will be linked to or overlaid with the housing data. And then the plan is to model and analyse this linked data to get an idea of where in Greater Manchester the condition of housing may be impacting upon the health of local residents. So, for example, if an area is shown to have old housing with problems of damp and mould and increased respiratory conditions in that area, then it might be suggested that the damp condition of the housing is contributing to the respiratory condition of its residents. And after that, appropriate policy interventions can be designed. So following this modelling, GMCA are going to develop a series of use cases, which was new lingo to me until recently. So for anyone who's not familiar, use cases are scenarios or examples that illustrate how a particular intervention could work in practice in the real world. So these will be used to develop appropriate housing policy interventions. The project is roughly 18 months in length. We're in the early stages of that period now. And the Healthier Futures Research Platform, our platform, are supporting the project in various ways, including some of our theme leads are supporting the data access and data modelling stages. But we've also been very involved in this earlier phase because we've been rapidly reviewing the evidence on the links between poor quality housing and poor health. And that is so that the GMCA can identify the most relevant, the most pertinent health outcomes from Greater Manchester residents' health data, that are shown to be related to housing. So that means that the housing and health model will be informed by evidence in this way too. And so, yeah, this is what we've done, a rapid evidence synthesis of the health impact of poor housing. Rapid evidence synthesis, or RES, is a method that's been developed within the Applied Research Collaboration, or ARC, here at the University of Manchester, and it's been used with success in the past to support and to inform stakeholder decision-making in and around Greater Manchester. And it uses systematic and explicit methods to rapidly search for, to identify, to assess, and to summarise existing evidence on a given topic. In practice, a protocol for the RES is discussed and developed in close collaboration with the stakeholder, and in this case, it involved Healthier Futures and GMCA discussing the nature of their work, the scope of the rapid evidence synthesis, and the types of question to answer, and the types of evidence, therefore, to search for. So we aim to answer these research questions. Firstly, what is the evidence that housing quality and condition affects the physical and mental health of residents? And secondly, what is the evidence that improving housing quality and condition affects the health of residents? And this method involved systematically searching key resources of evidence, including the scientific databases Medline and the Cochrane database of systematic reviews. And these were also supplemented with like hand searches in Google Scholar and also the Overton database. We also looked for, relevant guidance such as that by NICE. And RES, for anyone who's not familiar, has many of the same sort of like components or techniques as a traditional systematic review, but these are streamlined for efficiency and rapidity. So if I've got my timelines right, this was requested in February, the protocol was agreed in about March, and then the piece of work was delivered in May, and it was about 6 weeks of work over a 3-month period. So relatively speedy. And the focus in that time is on finding those study designs that are best able to answer the research questions. So where possible, we're looking for identifying existing evidence syntheses like systematic reviews that are of a high quality. But in the absence of these, which was not the case in this one, as you'll see, we also look for individual primary studies that are of a really high quality. Then the data is critically appraised, generally by adopting the critical appraisal judgments of the original review authors. And then the data is synthesized narratively and assessed in terms of its relevance to the research question and its certainty. The evidence for each health outcome is given a certainty rating, which ranges from high, moderate, low to very low. And we use GRADE to do this, which is an internationally recognized grading system. I'm sure many of you are familiar with it. And it essentially indicates the level of confidence we can have in the evidence on a particular health outcome. It's not about rating the certainty of single studies, I should say. It's about rating like bodies of evidence, which have been ideally summarised in a systematic review, which hopefully provides a nice and trustworthy summary of the evidence, which is then graded. So I've used these colours here, green and amber, here and in later slides, to indicate our level of confidence in the findings. We used PCOS, which I'm sure, again, many of you are familiar with, the PCOS framework to structure our eligibility criteria, which you can see summarised here. We searched for systematic reviews of both quantitative and qualitative research related to any adult and child population. That includes the general public and also clinical populations. So, children with a diagnosis of asthma. We looked for studies from a range of residential housing factors, but particularly those related to the physical condition, the physical structure, or the physical state of repair of housing. And we were prepared to consider a wide range of primary study designs and any health outcome. We had a primary focus on like physical health outcomes, but we also considered mental health, healthcare use, quality of life, and health-related behaviours. We also looked for evidence from high-income countries because we considered this evidence to be more comparable to a UK and GM context. So in total, we included 40 systematic reviews published between 2000 and 2004. Now, collectively, these reviews synthesized hundreds of primary studies published from the 1980s to today. Most of that research was published from the year 2000, and most of it was published in North America, with only a minority from the UK. Those are only crude judgments, I should say. I didn't systematically assess, date and location. But more than a quarter of those systematic reviews were published by Cochrane. We also identified some relevant NICE guidance related to the health impact of cold homes and indoor air quality. So this is a slide I recently presented to colleagues from the GMCA and the NHS Strategic Intelligence team. Ordinarily, I think presenting to a majority academic audience, you might typically expect to see limitations and implications of the findings presented after the results, but I'm flipping it on its head today. I've kept this in at this point in the presentation because I think it highlights a really interesting and a really important part or distinction maybe of the RES process when producing work for stakeholders outside of academia. And this slide is all about supporting audiences to interpret the evidence in terms of like what it is, what it means, and how much confidence we can have in it. I think it's worth briefly summarising some of this for you today. Because in an ideal world, I would have been able to go back to the GMCA and be like, hey, look at all these clear, undisputable, wonderful causal pathways between housing and health. But the consensus in the academic literature seems to be that the causal pathways are inherently very complex, as with many of the social determinants of health, and this is reflected in the evidence. The evidence we found that answers question 1, again, as you can see on the slide here, the research question number 1, is that stuff was mainly from non-experimental observational research like cross-sectional and cohort studies. So the nature of that evidence is indicative of like an association or a relationship between housing and health. Cross-sectional research is useful for finding potential relationships between variables, but it cannot establish causality. Temporality. What came first? Was it poor housing or was it poor health? Cohort studies, by comparison, are obviously stronger at establishing temporality, and they can suggest causality through longer term observation. But these studies generally still face issues around like confounding factors. And according to the grading system we use to assess certainty, observational studies are automatically graded as low certainty or low confidence. This evidence can be upgraded to high or moderate, but in the case of this RES, we were generally only able to have low confidence in the evidence that answers question 1. Whereas we were able to have slightly more confidence a fair bit more confidence, I would say, in the evidence related to question 2, because this stuff generally came from experimental studies, so randomized and non-randomized control trials, which, are obviously better at establishing temporality and inferring causality. So question 1, how does housing quality and condition affect health? We were able to broadly theme this evidence, as you can see here, under aspects of housing condition and design and indoor air quality. And this included things like cold indoor temperatures, the built housing environment, housing age, home hazards and light, as well as indoor air quality factors such as damp and mould and indoor allergens. We also identified other partially relevant evidence, and it was considered partially relevant but still worth highlighting because it speaks to the more wider life circumstances of residents rather than the physical state of repair of housing. So that's things like housing tenure, housing insecurity, crowding, and other indoor pollutants or allergens that can come about through things like cooking practices and pet ownership. So there's a relationship between housing condition and health. We identified guidance by NICE, which highlighted a pretty clear relationship between cold indoor temperatures and excess winter deaths in the UK. Most excess winter deaths and illnesses are not caused by hypothermia or sort of extremes of cold, but are predominantly from exacerbated cardiovascular and respiratory conditions. And that risk increases as the temperature falls further. We also found evidence from one review of a relationship between exposure to cold indoor temperatures, such as those 18 degrees or below, and increased blood pressure, reduced physical functioning or physical performance, and some sleep outcomes, including a greater difficulty falling asleep and also a greater need to urinate during the night, which is a key factor for sort of sleep disturbance. So therefore overall sleep quality. But this review showed mixed and therefore inconclusive evidence of a relationship between cold homes and viral infections and COPD symptoms. Older people and those with chronic health problems were more likely to have a negative health impact from the cold. There was evidence from 3 reviews that suggested that aspects of the built housing environment, so namely like building type and building materials, may be associated with increased asthma in children and poorer mental health in adults, including depression. Specifically, living in a house with a basement or an underground room or in a trailer was associated with a higher risk of asthma in children. And then for adults, living in areas where only a minority of homes had private gardens was associated with an increased risk of depression, as was living in a house with like a deteriorating condition. So that includes things like non-functioning kitchen facilities or large areas of like crumbling plaster and peeling paint. Also, the evidence from one review suggested that living in older homes or older houses may be associated with increased asthma symptoms in children. Unhelpfully, this review didn't really define what old was, so take your guess. The evidence from one review suggested that hazards within the home are associated with increased falls in older adults. The issue, again, with this review is that the authors generally didn't specify the type of hazard, apart from for one study which reportedly assessed hazards in the bathroom and hazards on the stairs. In addition, one review investigated the relationship between natural sunlight and light at night in the home with health. And the evidence from this review suggested that natural morning light was associated with reduced depression, improved mood, and improved sleep outcomes, whereas inadequate natural light was associated with greater risk of depression and of falling at home. There was also an association between increased light at night time, so that would be a form of like artificial light, and poorer health outcomes. So that's greater risk of plaque buildup in the arteries, higher blood cholesterol, higher BMI, abdominal obesity, blood pressure, diabetes, depression, quite a few, and sleep latency as well, which is the time it takes to fall asleep. The evidence from 5 reviews indicated a strong association between dampness, visible mould, and mould odour in the home with new cases of asthma, the worsening of existing asthma, increased wheeze, which is an asthma symptom, and poorer respiratory health. And the impact of damp and mould appears to be strongest in infants, second strongest in children, and third strongest in adults. And we also identified NICE guidance, which supported these conclusions. In addition, one review looked at the relationship between various indoor allergens. So those are sort of allergens related to infestations, house dust mites, cockroaches, mice, that sort of thing. They looked at the relationship between those sorts of allergens and asthma and wheeze, but the evidence was mixed and therefore inconclusive. As I mentioned, we also found like sort of partially relevant evidence that maybe less immediately important and relevant to the sort of physical state of repair of housing, but is still worth highlighting. And this evidence from 3 reviews suggested that housing tenure and housing precarity are associated with increased anxiety and increased depression. For people from refugee and asylum-seeking backgrounds, aspects of housing security were consistently associated with greater anxiety, greater depression, stress, and poorer quality of life. And this included things like insecure tenure, the threat of home eviction, plus a lack of access to housing due to discrimination. There was no evidence in this review of a relationship between housing tenure type and asthma, so that's like private rented, social housing, or home ownership. In addition, the evidence from 3 reviews suggests that there's an association between household crowding and a range of like close contact infectious diseases. So gastroenteritis, upper and lower respiratory tract infections, bacterial stomach infections, that sort of thing, and also with depression. But this review found no evidence of a relationship between crowding and asthma. So there are other like relevant indoor pollutants and allergens, but these mainly came in the form of like pet allergens and pollutants from domestic combustion, so cooking, and other domestic practices like household cleaning. And the evidence from 4 reviews on domestic practices said that suggested that there's an association between particular indoor air pollutants arising from combustion. So that's things like volatile organic compounds and particulate matters, among others. And also between those types of pollutants and poorer health outcomes, and also between household cleaning products and poorer health outcomes. So these are sort of associated with poorer respiratory functioning, asthma symptoms, COPD, and cancer. And NICE guidance on this also highlighted that certain pollutants and pet dander can be linked to respiratory symptoms, cardiovascular symptoms, and neurological symptoms. Regarding pet allergens, there was mixed and therefore inconclusive evidence from one review regarding the relationship between having household pets and childhood asthma. This evidence mainly related to dogs and cats. So question 2, how does improving housing impact health? Again, we themed the evidence, as you can see here, into housing condition and design and indoor air quality. This included like warmth and energy efficiency, retrofit measures, home hazard reduction, improving lighting. It also included measures like controlling or reducing damp and mould, indoor allergens, and lead exposure. And the evidence from 4 reviews suggested that warmth and energy efficiency interventions, and that can include things like installing or upgrading or repairing central heating, installing insulation, like wall insulation, cavity wall insulation, roof insulation, or both. Can also include the installation of double glazing or a combination of any of these. That these intervention types improve the general health, asthma symptoms, and respiratory health of adults and children. But the evidence for the intervention's impact on the health of older adults was mixed and therefore inconclusive, as was the evidence for the impact on the mental health of adults of all ages. Similarly or relatedly, retrofit interventions may have a positive impact on general health, but the evidence for their impact on respiratory and mental health was inconclusive. But a noteworthy issue here in the literature is that the content of these retrofit interventions was quite poorly described, so we're not really sure what they included or what they entailed exactly. There was some qualitative evidence here on sort of actually the positive impacts of warmth and energy and retrofit interventions. There's a wide range of reported positive outcomes, many of which could like certainly factor into or mirror quality of life. So there's things like improving warmth increased the amount of usable indoor space, which in turn happened to enhance like privacy within the home, strengthen household relationships and family functioning. It also meant that there was like more safe space for children to play in and just generally like reduced clutter. One study actually also reported greater opportunities for educational study for the children in the home. And 2 studies also reported like improved diet, which was linked to increased income from reduced energy bills, as well as like greater use of the kitchen due to it being like warmer and therefore a more comfortable space to be in. In terms of other positive impacts, there was evidence of like improved well-being, happiness, life satisfaction, reduced respiratory illness and stress, and reduced smoking and sedative use. So the evidence from one review suggested that taking measures to reduce damp and mould in homes improves asthma symptoms, it improves respiratory infections, both of these in adults. And then in children, it reduces the number of emergency and inpatient hospital visits, which potentially implies that this helped to reduce like severe asthma in children. But by comparison, no effect of these interventions was found on like asthma symptoms overall, so maybe the more like day-to-day experience of asthma or respiratory infections in children or asthma symptoms in older adults. There was a relatively large number of systematic reviews, 10, that related to home hazards interventions. And these can include things like identifying hazards, making environmental safety changes or like adaptations around the home. So stair gates, smoke alarms, non-slip bath mats, that sort of thing. These interventions tended to include an educational component or like a sort of behavioural strategy component, such as avoiding the build-up of clutter. And the evidence from these reviews indicated that improving home safety, reducing home hazards, these together reduce the number and the rate of falls in older adults, but only specifically when these interventions are targeted at older adults who are at risk of falling. As well, the evidence suggested that providing home safety equipment appeared to reduce the injury rate in older adults. But no effect of these interventions was found for health-related quality of life, for fall-related fractures, and falls requiring hospitalisation or medical attention. Additionally, the evidence from one review indicated that the impact of improving artificial home lighting by giving participants a single floor lamp for their lounges, their living rooms, had an inconclusive effect on their physical and their mental health. So the evidence from 7 reviews indicated no effect of various interventions that had been used to try and control indoor allergens. That's like mostly house dust mites the evidence was for. There was no effect of these measures on asthma, on lung functioning, or on eczema outcomes. Generally, these interventions included like pesticides, air purification, removing carpets, super highly efficient vacuuming, changing mattress covers, general like pest control, or removing like the household pet. And then similarly, no effect was found of household environmental interventions that were designed to sort of reduce lead exposure. There was no effect of these found on the blood lead levels of children. Again, these were kind of mainly dust control measures, I believe. So briefly, next steps and other considerations. That was a reasonably quick whistle-stop tour of the RES findings. The next steps for this project involves planning out how to link the data between housing and health outcomes in Greater Manchester. And the results of this RES are going to give the GMCA a steer on health outcomes that they might want to consider, but there are also plans underway to convene a roundtable discussion with relevant experts in sort of housing and health to further discuss and to further interrogate the evidence and decide the health outcomes of greatest relevance. This RES has also brought up other considerations. I think I mentioned that, systematically, these reviews have included hundreds of studies, but only a minority of these are from the UK, which might indicate gaps that are worth further research. The final point I'd like to make before I open this up to comments and questions is that this RES didn't consider costings or like cost effectiveness of the various interventions, but given that the eventual aim of the GMCA is to propose cost-effective policy interventions that improve housing conditions for the largest numbers of people ideally possible, this question is very relevant. Is this stuff going to be cost-effective? So thank you for your attention.